Welcome to the Edelheit Experience, a compelling conversation about revolutionizing health and well-being, bringing you rich stories and lessons learned from leading corporate executives. Now, we'd like to introduce your host, Jonathan Edelheit.
Welcome to Healthcare Revolution. I have an amazing speaker with me today. I think this is the most exciting session, for the event, really, that I feel falls around our moonshot around costs and reducing healthcare costs by about 25% by 2025. And that's Dr. Abramson. Dr. Abramson, thank you so much for joining us.
Jonathan, thanks for having me.
So with healthcare costs continuing to rise and the pharmacy side being a big part of that, and that's why a lot of the pharmaceutical companies and pharmacies, CVS bought Aetna, Walgreens made moves, is that this is becoming a huge burden on employers, on employees, and nothing's changing. It's not reversing. And you wrote a book on this, that really talks about this. Tell us about your book and why you wrote it.
Well, I wrote it because the story is not getting out about how much American healthcare costs and how the health of Americans has been just plummeting over the last 20 years. And the underlying problem being that doctors are getting knowledge that's produced by and for commercial interests. And it's a story that's not being told.
And people would typically think that pharmaceutical companies, PBMs, they're there to take care of you, right? And to make you help you get better. But at the end of the day, it's almost like dealing with the mafia or walking into a casino where you're going to go play the slots. And, 99% of the time, the house always wins. And, people need to change their philosophy of who they're working with, right?
Right. We're kind of schizophrenic on this. I mean, 80% of the American public thinks that drugs cost too much and that drug companies are primarily interested in their own profits. And yet there's this hope that medical innovation will provide us with therapies that are previously unavailable, and that our future good health is going to be dependent on the pharmaceutical companies' innovation rather than the way we live our lives.
I think that's very powerful, right? Because the way we live our lives could make us not need the pharmaceuticals that they keep putting out to make us think we need these to live our lives.
Well, yes, and it's even more. If doctors understood first and the public understood what really goes into making us healthy, then we would see the extent to which our efforts to achieve health and the money we spend on trying to achieve health is being misdirected and misused, because the primary job of the pharmaceutical industry, regardless of what they try to tell us, is to maximize their revenues and return those revenues to their shareholders. It's not to make us healthier. They spend a lot of money trying to convince us that it's to make us healthier, but it's not their primary job.
And if we were just to dive into a little bit of to set the tone, I think, for what we're going to discuss, is when we say they spend a lot of marketing, to make us think this is the way it is how do they approach that with nonprofits and other things that they establish?
So as we get into this discussion, you'll see that all of the channels that provide healthcare information, be it to doctors or to the public or to purchasers, almost all of the information about pharmaceuticals comes from the drug industry itself. And in terms of the universe of knowledge that doctors receive from new research, 96% of that knowledge is about drugs and devices. It's not about how to make Americans healthier. Less than 4% of the money we spend on research is about how to make Americans healthier.
That's very scary. And share with us some of your background in this space. I know you were, whether it's DOJ investigations, I'd love for you to talk about also some of the fines and lawsuits that some of the pharma companies have been involved in to kind of set this stage of why people really need to listen to the message that you're sharing, because of how these companies operate.
Yeah, so the sickening is really my life work. And I was a family doctor. I was trained as a family doctor. I went into private practice in 1982 after having been in the public health service and having done a Robert Wood Johnson fellowship, learning about statistics, epidemiology, and research design. And I was trained as an academic physician to be an academic physician, but decided that my real calling was to go and practice in a small town and be a family doc and make house calls and take care of people who are dying and do all the things that a family doctor does or used to do anyway. And I enjoyed that. That was my calling, and I thought I would never leave family medicine. But from 1982 through until the mid 90s, things were going pretty well. But around the mid 90s, it started to become clear that the information that I was getting as a disciplined doc was largely colored by the drug industry. And what kind of what changed my life was reading an article about Vioxx, the anti-inflammatory drug that was withdrawn in 2004 from the market and the biggest drug withdrawal ever. And this article in the New England Journal was basically minimizing the cardiovascular risk associated with this drug Vioxx that provided no better pain relief than over-the-counter anti-inflammatories and was supposed to have an advantage of being safer on the stomach. And that was the claim, and that's why $2 billion were being sold in the United States. But it turned out that Vioxx was a significantly more dangerous drug. It more than doubled the risk of heart attacks and strokes. And when I saw that data in the FDA website, and realized that my patients were coming to ask me for Vioxx because it was being advertised so much, and the data from the New England Journal wasn't telling the full story, I decided to leave my practice and to write a book that came out in 2004 called Overdosed America. A week after that book came out, Vioxx was pulled from the market. It wasn't my doing. It certainly wasn't my doing directly, as another study had come out that showed that Vioxx was dangerous and more than doubled the risk of heart attacks and strokes. And it was clear to Merck at the time, we didn't talk about this, but it seems obvious that they felt they couldn't get away with hiding a second study that showed that Vioxx was dangerous. And so Vioxx was pulled, and I was the last guy who wrote the book about this issue. And I was all over the TV, the Today Show, and many national television shows. Lawyers saw me on TV explaining the situation with Vioxx in a way that had scientific integrity and was comprehensible to ordinary Americans. And they started to ask me to be an expert in national litigation about what the drug industry was doing. I did that for about 10 years. So I spent 10 years inside corporate computers, literally as an expert in litigation. You sign a confidentiality agreement, which means that what I see must stay secret, and I honor those agreements. But I would get to see the corporate hard drives from the executives, from the scientists, from the marketers, and I could put together how the drug companies were creating data and manipulating that data to serve the marketing goals of the drug companies and communicating that data to doctors in a way that served their sales goals and was pretty much ignoring the health consequences of what they were doing. If we could go to the slides, maybe I can show you a little bit about what's going on here. And if we could go to maybe slide number 7. So this shows how the context in which the information that doctors receive as evidence-based medicine changed so radically in the 1990s. This graph starts in 1994, but in 1991, 80% of clinical trials were done by academic medical centers. And then you can see it went down from 63 to 55 to down in 2004, it was all the way down to 26% of studies were done in academic medical centers. And the other 74% were done almost entirely by the drug companies. And what happened, if we go to the next slide, so the drug companies are now paying contract research organizations to carry out their studies. And this is a slide that was actually shown in litigation. It wasn't litigation I was in, but it shows how the drug companies think about their data. And it says data ownership and transfer. It's from Pfizer, and it says Pfizer sponsored studies belong to Pfizer, not to any individual. And that means their data belongs to Pfizer and it's proprietary corporate information. And the second bullet point says the purpose of data is to support directly or indirectly marketing of our product. And that is a totally shocking statement that Pfizer says its purpose in producing data is to support its marketing. Now, in 2009, I served as a consultant, an unpaid consultant to the Department of Justice and the FBI in a case involving Pfizer. It involved an arthritis drug like Vioxx. It was called Bextra. And I had been involved in civil litigation with payers trying to recoup the money they paid for this drug that had been marketed off label and appeared to have some cardiovascular risk. I testified in front of the FBI and Department of Justice, and 6 months later, they keep their cards very close to their chest. 6 months later, I saw a press release issued by the Department of Justice, and they had issued the largest fine for any matter ever in US history against Pfizer. Largest fine. And then in 2010, I testified in federal district court in a case in which Kaiser Health Systems sued Pfizer for fraudulently marketing its drug Neurontin for off-label use and misrepresenting the results of the studies. And the jury in that federal district court found Pfizer guilty not just of fraud, but of racketeering violations. This was the first case in the United States where a drug company had been found guilty of racketeering. Not many doctors know that this case even happened, and almost no doctors know what was told to the jury. In my testimony, in the second chapter of Sickening, there's a lot of my testimony to the jury explaining to ordinary people the scientific fraud that had been perpetrated on doctors that convinced them to prescribe Neurontin for the off-label use of painful neuropathy. It hadn't been approved by the FDA. Its own consultants had said, you're done, it doesn't work. And yet Pfizer went on and continued to market that. And if we could look at the next slide, we get to see how deeply pervasive this commercial takeover of the knowledge that even the best doctors believe to be true. This is a summary of a beautiful study that looked at, in the last study, we saw that 26% of clinical trials were done by academic medical centers by 2004. And the academic medical centers had to yield a lot of ground to the pharmaceutical industry to maintain that 26%, because that could have been pulled out of the academic medical centers too. So this is a study that looks at the contracts that are signed between academic medical centers and commercial entities hiring them to do research. Two circles are critical. The 80% is, in your best judgment, would your office allow a clause in a multi-center clinical trial agreement saying that the sponsor will own the data? So 80% of academic medical centers who are conducting commercially sponsored research give away their rights to the data and let the drug company own the data. And then if we drop down in the slide to the circle that has 50% in it, that 50% says that the sponsor will write up the results for publication. The sponsor will write up the results for publication, and the investigators may review the manuscript and suggest revisions. What this says in plain English is that 50% of these contracts say that the sponsor can ghostwrite the article without the authors, and the only rights the authors have is to suggest revisions, but they can't insist on it, revisions. So these are the terms under which the articles are written, the articles that are submitted to medical journals are written. And many people think that, well, this stuff doesn't sound right, but we've got peer review, and the peer reviewers are going to straighten this out because they're going to get the data. And even though the commercial interests are biasing what the data, how the data are handled, it'll all get washed out in peer review because science is objective. Well, it turns out that peer review, the peer reviewers who get the manuscripts and decide whether they accurately and reasonably completely represent the data from the clinical trial, the peer reviewers don't get to see the data. The data are not submitted to the peer reviewers or the medical journal editors. And the data are not submitted to the experts who write the clinical trials that set the standards for practicing docs, standards of high quality care. So if we go to the next slide, this is the real situation. And this shows the extent to which the information that doctors rely on and the experts who write clinical guidelines rely on are the data are unvetted and unverified, and the doctors don't know it, and the purchasers don't know it. So in the little rowboat there, we've got a hardworking doctor, and he's looking for evidence-based medicine because he wants to be a good doctor and bring the best of medical care to his patients. And he's looking at what is above the waterline in this diagram, above the waterline from the iceberg. And what does he see? He sees the documents that are available to the public. So he sees the peer-reviewed journal articles, and he sees the clinical practice guidelines, that neither of which the authors have been able to get the data. The peer-reviewed articles, no data, and the clinical practice guidelines are a compendium, an amalgamation of the published articles in the medical journals, but they have no more data than the peer reviewers and the medical journal editors had. And then they have drug company marketing up there, and a significant amount of information gets transferred that way. And then there's a stack of medical journals like every doctor has on his or her desk. That's what the doctor is seeing when he's looking for scientific evidence. But if we look below the waterline, and this is what I got to see in litigation, this is a long answer to your short question, but what I got to see in litigation was the actual data. If we start at the bottom of the iceberg, we get completed case report forms. Those are the Each participant in a clinical trial has a case report form, and each visit or lab data or whatever interaction is entered on those case report forms. And those case report forms are collated into electronic patient level data sets, and the data sets are transferred into clinical study reports, which are about 3,000 pages and are tabulated and are searchable. Now, the key point here is everything below the waterline is confidential corporate documents. And the peer reviewers and the clinical practice guideline writers don't get to see it. But whatever excuse is made for not getting this information to the docs who peer review, to the medical journal editors, to the guideline writers, it doesn't pass the sniff test, because the clinical study report is made for virtually all major clinical trials. It's 3,000 pages, but it's a PDF document, and it could be transferred with the submitted manuscript, and the journals could easily have access to most of the data they would need to certify that the articles are accurate. But they don't do that. The International Committee of Medical Journal Editors does not require submission of those clinical study reports. So we're in a situation now, we can go back and talk a little bit about the overview of American healthcare, but this is the heart of the problem. Even though drugs only constitute 17% of total medical expenses in the United States, we've got a tail wags dog situation, because the information that is generated by the drug companies, who pay for about 86% of clinical trials, the information that's generated by the drug companies is used as marketing material, but the doctors don't understand that. The doctors think they're practicing evidence-based medicine. So when purchasers, healthcare purchasers, and especially non-healthcare related businesses, are buying healthcare for their employees, they're buying healthcare that is largely directed by the commercially influenced knowledge that physicians receive as legitimate knowledge, that they've been trained to receive as legitimate knowledge, but is biased towards using their very expensive products. And one more thing, and then I'll stop my soliloquy. In the United States, unlike other countries, we do not have a formal health technology assessment. What drugs we should prescribe. Other countries, other wealthy countries, the UK is a perfect example, have a method of health technology assessment. So an independent organization assesses the clinical value and the economic value of new drugs to make recommendations on which drugs should be covered and what the pricing should be. And so doctors can go to that source and find out what's the best treatment for their patient. But in the United States, we have a system that is largely commercially controlled without independent oversight. And the docs have been trained to practice evidence-based medicine that relies on the commercially pushed information. So we have no such mechanism for ensuring that doctors get accurate information about which of the new therapies are going to be of the greatest value for their patients.
Now, for me, I feel like I was blown away when I first heard, what you were saying, because I've always thought that there's this academic journal process, and these academics review all this clinical data on pharmaceutical drugs and independently recommend or don't recommend or share it. But what you're saying is there is no independent review of drugs because they don't have the data. It's basically the pharma companies are just telling everyone, here's our data, take it, and you're not allowed to look at anything. And in a lot of cases, that data could actually, they're misconstruing the data to make it look helpful when it could be harmful or not as effective.
That's exactly right. And that's what I learned as an expert in litigation. That was my job, was to find out the extent to which that happened and how it happened so I could testify about it. I was doing a big live radio show last week and explaining this story. And a doc called in and she said, I do a lot of peer reviewing of clinical trials. And she acknowledged that she doesn't get the data. And her call was, you're making an unreasonable request because we peer reviewers don't get paid for doing the peer review. And it would just be too hard if we got the actual data and had to assess it for ourselves. In a sense, not in a sense, she's correct. Volunteers can't do this, but that doesn't mean it shouldn't be done. What's happening is the peer reviewers have made this kind of negotiation with themselves that they're doing the best they can do. But if you wanted my recommendation, I would say go on strike, stop it. There's prestige in doing peer reviews, and people want to be good citizens. It has to do with academic credibility to do peer reviews, but we're doing the wrong thing. And businesses are left in the position of having, businesses can't go off on their own and say, look, this system of peer review, the system of research is broken, the system of peer review is broken, the system of clinical practice guidelines is broken. We don't have cost, it's against the law for the federal government to do cost effectiveness research. And businesses, as they start to learn about this, are going to understand how this system is so tilted towards commercial interests. But how to extricate ourselves from this is the real challenge. And the first step in it is for the doctors to understand that the information that they're getting is commercially biased. It's not, so-called evidence-based medicine is not independent of commercial bias. And it's certainly not transparent.
Yeah. And what's interesting is I think in the employer space, everyone is focused on the PBMs, the pharmaceutical benefit managers, and what's the discounts are they providing, or how do we find a transparent one? And I think to set the stage, first we had to go one step further back and say we need to look at the pharma companies and understand how this is in some ways a scam and the system is totally rigged, to understand that, employers, people getting the prescriptions, I look at it as the pharma companies are the predator, they're the prey. And at least if you understand the system of how this is biased and is skewed, you could look at it in a different light of like, how do we actually approach this? And what would be great, Dr. Abramson, if since we've set this, I think the stage for that, if you could share some of the drugs and how they're pushed as that primary drug when they're less effective, and how cost significantly more, so people can understand what you just showed, like how this plays out in our everyday lives.
Exactly. So I'm going to show two drugs, talk about two drugs, and it's exactly what you're saying, Jonathan. The information that the docs are getting is biased towards expensive drugs. And then the PBMs get into making arrangements with rebates, which are sometimes called kickbacks, colloquially, to get these drugs in a tier that is attractive to patients with low, to have low copays that don't represent anything near the total cost of the drug. So if we could go to slide 11. So Humira has been the best-selling drug in the United States for many years. It is approved for now 9 indications. The first indication, and I believe the most common use, though the AbbVie won't tell me that, is rheumatoid arthritis. And I think most people recognize Humira as a drug for rheumatoid arthritis. So this is from the FDA approved label for Humira. Now, a little bit of background on labels. The drug companies own the labels. The FDA has to agree to the label based on their analysis of the science. But the drug company owns the label. So any hint that the label is somehow biased against the drug company is not valid. And that's just a background. And sometimes there's a little edge amongst doctors thinking that the drug company is the FDA exercising its bureaucratic muscle. It's not. The drug company owns the label. So this is the first indication for Humira in the FDA-approved label. And you can see the bolded text says, Humira can be used alone or in combination with methotrexate or other non-biologic disease-modifying anti-rheumatic drugs. So Humira can be used alone or in combination with other drugs. And Humira is often used as the first drug, first therapeutic agent for people with rheumatoid arthritis. And it's often used alone as the first agent for people who do not present with severe arthritis. So now I want to show this to the business folks, especially because this information is in the label. And if we go to the next slide, so this is a chart of a table of results from one of the studies that the manufacturer of Humira did. And the study compared methotrexate, MTX, to Humira and to the combination of Humira plus methotrexate. But for this purpose, the label said that Humira is approved as single drug therapy for rheumatoid arthritis. So let's compare Humira, which costs about $72,000 a year, to methotrexate, which costs about $480 a year.
It's a big difference.
Big difference. So it's about somewhere around 200 times. So ACR 20, ACR 50, and ACR 70 are the American College of Rheumatology criteria for 20% improvement, 50% improvement, and 70% improvement. All important categories. And if we just go through, let's look at ACR 20 first. And we see after 1 year, methotrexate has 9% more improvement than Humira does. And after 2 years, methotrexate has 7% more improvement than Humira does. Methotrexate costing about a 200th as much as, a little less than a 200th, but close, as much as Humira. And if we go to ACR 50, which is a more general criteria of success, we see that in week 52, methotrexate's 5% better than Humira. And after 2 years, it's 6% better than Humira. And if we go to ACR 70, there's not that much difference. They're pretty much close to the same. But if we look at the smaller category below, which is major clinical response, which means that 70% improvement has been sustained for at least 6 months, we see that for major clinical response, which you could argue is what doctors would want to know, that's what they would want to maximize for their patients. And we see that methotrexate is 3% more effective than Humira, more effective. So if I were a non-healthcare related business owner, I would be interested in how many of my employees were using Humira as a single drug for rheumatoid arthritis instead of methotrexate. But here's the problem, is if the business owner understands this and wants to work with the HR people to prioritize the use of methotrexate instead of Humira, and this could be done by structuring the formulary that the PBM, they have probably discharged this to the PBM, and the PBM is probably getting very attractive rebates from AbbVie for promoting or making Humira readily accessible to the employees. But I would want to have a program that at least suggested to doctors that there's no evidence of superiority of methotrexate over Humira as a single drug therapy for rheumatoid arthritis. That's what the facts show. The problem is that that's not the community standard, because AbbVie, the manufacturer of Humira, has spent more money advertising Humira to the public and marketing to doctors than any other drug for most of the last 8 years or so. So if there was an attempt by a single business to minimize the use of Humira as the first drug for rheumatoid arthritis, there would be a perception that the employer was imposing inferior care on their employees. And this is the problem, because the community of medical knowledge is so tight. The belief that Humira is the superior drug is so tight that one business can't do it. Business has to form into a large coalition that creates, basically establishes its own health technology assessment organization to make authoritative statements about the data review and what the greatest value, the highest value-based care that can be provided to people presenting with an initial diagnosis of rheumatoid arthritis. So
to sum that up, though, is that basically, the majority of everyone is getting a drug that costs 200 times more, that's less effective. And the PBM is also most likely getting big rebates, an incentive to make sure that drug is filled. Am I correct?
That's correct. So there's two stages to this. One is the information that the doctors are getting, and the other is the incentives of the PBM.
Yes. Yeah. Because we think the PBM somehow protecting us, a gatekeeper, but it's kind of like everything is just rigged against us. And if somebody were to say, well, this slide you're showing, this data, this can't be accurate, where did this come from? Maybe there's other studies that show it's more effective. What would your response to that be?
My response is that AbbVie owns this label. They own it. If they had other data that they wanted to bring in, they could bring it in.
So this is AbbVie's data that they're sharing, saying it's less effective, but nobody's paying attention to it because they're over here spending all the money on marketing and everything, and people aren't actually, taking the time to really look at this.
That's exactly right. And it's so important, Jonathan, because the question you just asked me, why aren't people going to say, look, this is just bias, this is studies that were done by people who want to try to save money? That's the natural instinct, and that's what the doctor's natural instinct is. But this is AbbVie's data. They put it in the label.
Yep, it's fascinating. And then also, can you share with us if let's say employers somehow were able to get some of their employees to say, let's not go with Humira. How do the pharma companies handle that? Do they engage nurses, others to campaign to make sure that patient stays on Humira, or do they just quietly go in the night and say, oh, it's okay, someone went to the less expensive drug?
We're at a point, we're so far out on the pendulum swing now that nobody even tries to do this. The first step would be to have some gaming between Remicade and Enbrel and Humira on pricing. But that's not the point. The point is there's a fundamental flaw in the presumption that innovation is going to provide superior care, be safer and more effective. This innovation is exquisite. It's unbelievable. It's science fiction that we can get yeast or hamster ovaries or whatever biological mechanism we commandeer, that we can put genes in there for biologically active, to produce human molecules that are biologically active. It's unbelievable science, but that doesn't mean it's the best value-based care. And that's where we're missing.
It's interesting that you say that, right? Because everybody sees medications coming out for new treatments, new drugs, and they're thinking, oh, this is innovation. But a lot of it, as you said, it's science fiction. It's all about a company making money. And just because something new came out doesn't mean it's more effective than what's been around for 5, 10, 20 years.
That's exactly right. And I didn't make slides for insulin. It's a little bit more complicated story, but we had animal insulin from 1923 through 1982. The insulin that was used came from animals. And then the same kind of bioengineering. In fact, insulin was the first bioengineered drug. So instead of using animal insulin, there was bioengineered insulin that is called recombinant human insulin. The molecules are exactly the same as human insulin. The large molecule of insulin doesn't fold. The bioengineered form doesn't fold quite like the human insulin. So it's not quite 100% exactly the same, but it's pretty close. And that came out in 1982. And that insulin costs somewhere around $500 a year to use. And let me just preface this by saying that in the United States, 80% of the insulin that's used is used by people with type 2 diabetes. All people with type 1 diabetes need insulin, and a quarter of the people with type 2 diabetes need insulin. But because about 95% of diabetics in the United States have type 2 diabetes, it means that 80% of the insulin that's being used is being used by type 2 diabetics. So recombinant human insulin came out, and it had the prima facie advantage of being pure and being exactly human insulin instead of pig insulin or cow insulin. And it took over the market very rapidly. There was no evidence that it worked better, but it took over the market very rapidly because of the claims of innovation. And then in 1996, the first of a newer generation of bioengineered insulin called insulin analogs came out. And they rapidly took over the market, making the argument that they could better reproduce the physiological response of insulin, the natural physiological response of insulin. But the insulin analogs were also never shown to be superior to recombinant human insulin and probably animal insulin, though the test was never done. So now we have a situation where type 2 diabetics, about 90% of type 2 diabetics, are being treated with insulin analogs for about $5,200 a year instead of recombinant human insulin for about $500 a year. But there's not evidence of superiority for patients with type 2 diabetes. Yet doctors have been convinced because of articles that have appeared in medical journals, because drug companies have hired PR firms to convince doctors that tighter control is advantageous for type 2 diabetics, when that turned out not to be the case. For very tight control, it turned out not to be the case. And yet doctors believe that they can achieve better outcomes. Their patients are being treated, 90% of type 2 diabetics are being treated with insulin analogs, and we're spending in the United States about $20 billion on type 2, on insulin analogs instead of recombinant human insulin that could be invested in helping people to achieve healthy lifestyles that's going to cut down their risk of diabetes by about 50%. But we're taking that money that could help to seriously help to mitigate our diabetes epidemic, and we're throwing it away on these insulin analogs. And it just doesn't make sense. In the UK, the National Institute of Clinical Excellence, which is their health technology assessment organization, says that there's not a demonstrable benefit to the expensive insulins for type 2 diabetics, and that British doctors should start their patients, their type 2 diabetes patients who need insulin, they should start their patients on recombinant human insulin. And if for any reason there's an idiosyncratic need for the more expensive insulin, you go up. But we don't do that. And our doctors don't have a standard go-to place that would inform them of that. And our business owners have not gotten together and demanded that such information be independently analyzed so that all businesses can operate on it, so that they won't look like outliers who are trying to stint on their employees' care and health consequences be damned. So we need a system of getting good information out. And I have one more example of a label.
One thing I just want to just share with that is that, you say the businesses need to come together. And I look at some of the biggest players that could, potentially go against this would be the insurance companies, right? But then you've had CVS buy Aetna, so like that's an example of just a player being taken out, that could try to, create better equilibrium, and reduce, the bias or problems in the industry. It's very strategic. It's eliminating, I feel like, all the protections or the chances to negotiate or stop this is constantly being removed.
Yes. And in that case, the insurance companies are really in the same position as the HR people in non-healthcare related businesses, because the insurance companies, you'd think they want to save the money and spend $500 a year for equally effective insulin instead of $5,200 a year. You'd think they want to do that, but their primary value is in their subscriber base or their customer base, and they don't want to lose patients by going to more efficient care, the same way an HR director in a corporation doesn't want to piss off their employees by stepping the care down to equally effective but far less expensive care, because it creates the appearance of getting inferior care. So in a sense, the insurance company is in the same position as the non-healthcare related businesses.
Which is fascinating, because a lot of these cases you're talking about, they're getting inferior care. They're getting drugs that work less effectively for significantly more amount of money, but they've won that marketing game where people think if they get the less expensive drug that's more effective, they're actually getting inferior treatment.
Yes, or equally effective.
Yeah.
On that methotrexate chart that I just showed you, there was not a statistically significant difference between methotrexate over Humira, though there was a numerical advantage. But I wouldn't make the claim that methotrexate is superior, but I would certainly make the claim that methotrexate is not inferior to Humira.
Well, I'm excited for the next drug you're going to talk about, because I see ads on TV all the time for it. And for some reason, it's a name that I feel like just flows off my tongue. It sounds magical.
Right. So that's how it got on my radar screen, was the ads. And it was like, what's going on here? So we're going back to the FDA approved label, which the manufacturer of Trulicity owns. And the FDA granted the following two indications for use for Trulicity, two indications. One is as an adjunct to diet and exercise to improve glycemic or sugar control in adults with type 2 diabetes. First use. Second use is to reduce the risk of major adverse cardiovascular events in adults with type 2 diabetes who have established cardiovascular disease or multiple cardiovascular risk factors. And many diabetics who need insulin have multiple cardiovascular risk factors. So now let's go to the manufacturer-sponsored studies that the manufacturer put in its label. It owns the label. It put in the label, and the FDA approved the label, saying that it was scientifically accurate. So if we could go to the next slide, we're going to look at Trulicity as a single drug to lower blood sugar. So here we have Trulicity 0.75 milligrams, which is the lowest dose, the starting dose, Trulicity 1.5 milligrams, and metformin 1,500 to 2,000 milligrams. And if we look down if we go to hemoglobin A1C percent mean, don't look at the baseline is the same. But if we look at the change from baseline for Trulicity 0.75, Trulicity 1.5, and metformin, we see that they're almost identical. That Trulicity certainly does not significantly lower blood sugar better than metformin. Trulicity costs somewhere around, it's $690 a month. I think it's $8,200 a year. And metformin costs $4 a month or $48 a year. And we see for first-line therapy that Trulicity and metformin are approximately equal as blood sugar controlling therapy. So we don't see the difference, the 170-fold difference in price reflected in the ability to control blood sugar. But Trulicity got this additional indication that it significantly reduces cardiovascular complications in people, diabetics with cardiovascular risks. So let's take a look at how much it reduces cardiovascular complications in the next slide. So this is the if you look, it says table 14 at the top. MACE is major cardiovascular events. And the Rewind trial was a trial that the Trulicity manufacturer sponsored. It had 10,000 people in it, and it was carried on for 5.4 years. And over those 5.4 years, we see in the first row of data, the endpoint was a composite of non-fatal myocardial infarction, non-fatal stroke, and cardiovascular death. That's a very valid endpoint. And what you see is that over 4 years, over 5.4 years, see Trulicity, the folks in the Trulicity group, 12% had the endpoint of a major cardiovascular event, and 13.4 had reached the endpoint in the placebo group. So over 5.4 years, 1.4% of the people didn't have a cardiovascular event who took Trulicity. And if you look at how many people you need to treat for a year to prevent one cardiovascular event, which by the way is a non-fatal cardiovascular event because there is not a significant reduction in fatal events, you have to treat 323 people with Trulicity for a year in order to prevent one cardiovascular event. And given the cost of Trulicity, that means that for each non-fatal cardiovascular event that Trulicity prevents, it costs $2.7 million. The way this minimal benefit got to be statistically significant is that the drug company sponsored the trial, and they sponsored an enormously large and expensive trial that had 10,000 people in it for 5.4 years. But you have to treat 320. The drug does not lower blood sugar better than metformin. And you have to treat 323 people for a year to prevent one event, which means that 322 people will not receive the benefit of the cardiovascular protection that the manufacturer is claiming. Now, there is some small benefit that's statistically significant, and yet there's no way that any reasonable healthcare system would conclude that spending $2.7 million to prevent a non-fatal heart attack or stroke was rational, especially when the drug company had all the money to do this huge study, but they didn't have the money to put a lifestyle intervention arm into the study to see if active lifestyle counseling would reduce the risk of cardiovascular events better than Trulicity. Now, interestingly, that study was done, and it was done for metformin back in the 1990s, a study that was federally funded, so you didn't get this bias of just drug or no drug, but the question that was asked is, what's the best way to prevent pre-diabetics from developing diabetes? And the study was set up to have a placebo group, a control group, a group that got active lifestyle intervention, and a group that got metformin. And it turned out that active lifestyle intervention reduced the risk of developing diabetes by 58%, and metformin reduced the risk of developing diabetes by 31%. So this diabetes prevention program study shows how effective lifestyle intervention is in a randomized controlled trial to prevent people at high risk of diabetes from getting diabetes. Now, if I were an employer of a large employee base, I would be looking to find the folks who are at risk of diabetes, type 2 diabetes, and who have type 2 diabetes. And I would create whatever incentive it took to get them to participate actively in a lifestyle modification program. And yet what doctors are hearing and what people are seeing on TV is take Trulicity because it'll reduce your risk of heart disease and stroke.
That's it's fascinating. And what's interesting is there's, in the corporate wellness space, there's this huge focus on, hey, you need to get people to be active and fit. And then there's the question of, is there ROI? Should you actually invest in it? You can't prove the ROI. And what's crazy is you're sharing is, a while back, a pharma company came out with a study that proved, if you had active lifestyle corporate wellness programs, that's going to be more effective. You may have helped prove the case, for the prevention and the corporate wellness programs like nobody else has done before, because nobody even knows that study or that report's out there that actually proves it, and that the pharma company actually is the one who sponsored it.
Yeah, no, the pharma company didn't sponsor it. The NIH sponsored it.
Ah, the NIH.
And that's a key fact because nobody, the statin manufacturers, statins have been out since 1987. No statin manufacturer has had enough money to sponsor a lifestyle arm in their statin versus no statin studies to see how to reduce cardiovascular disease. So I
would think that no pharma company would want to do that kind of study, because they might find that the people don't need their drugs and they're doing better without it, because lifestyle is a major factor in all of our health conditions.
That's exactly right. That's precisely correct. And I think the most important finding from the diabetes prevention program that was sponsored by the NIH is, I think, close to 100% of doctors, and I would bet a near equal number of HR people in business, believe that it's almost impossible to get people to make change. And yet this study, the diabetes prevention program that was published in the New England Journal of Medicine in 2002, shows in a randomized controlled trial, people made change and sustained change. They lost 10 pounds. They exercised 5 times a week as in the long arm of the study. And it's absolutely drug company and other commercial interests influence. It's a testimony to their influence over what we believe to be true, that the diabetes prevention program isn't the most frequently cited study, which absolutely proves that lifestyle intervention is effective in preventing diabetes.
That's amazing. So for employers, as we kind of, close out, what would be your closing thoughts or just of how do we approach this? How do we try to solve this? Is it focusing, like you said, on prevention and people's health and trying to incentivize there? Is it coming together, and forming associations of employers who, can try to influence this process? Because I think a lot of people are thinking, well, maybe the FDA is handling this for us, but they don't realize that they're just approving a drug. They're not approving, that they're not holding back drugs that are less effective. That's not their job. We're how do we solve this problem? Can we solve it?
And their job is also not to tell doctors what the most effective and efficient therapy is. It's not their job. It's not that they don't do their job well. They do their job pretty well, but it's not their job. We have nobody. We have no guardrails.
No watchdog.
We have no watchdog, and we have no guardrails to ensure that the information that doctors and consumers and businesses get will lead to the most effective and efficient healthcare. And in fact, we're spending $1.5 trillion more as a percentage of our GDP on healthcare every year, $1.5 trillion more than the average of the other wealthy countries. We would have $1.5 trillion more dollars to invest in our society if we spent what the other countries do. And yet 1,300 Americans die every day because our healthcare is so inferior to the healthcare of the other wealthy countries. So this is a disaster. It's a disaster on human terms, and it's a disaster on economic terms for business owners. The problem here is that there is a universe of information, and right now the commercial interests largely control that information, and they control it with the goal of maximizing the financial returns to their investors. And this is a dysfunctional system that has taken the United States way out on a limb in terms of healthcare dysfunction. In order to repair this, the last section of Sickening discusses what we need to do to repair it. And what we need to do, and this is so important for business owners, is the doctors can't fix it. Thanks. The doctors can't fix it. The businesses can't fix it, and the consumers can't fix it. They're not powerful enough. But if they work together, if the businesses form up into an organization that is designed to demand accurate information and permit independent analysis of the data so that recommendations can be made, like in virtually every other wealthy country about what is the most effective and efficient care. We need that organization. Businesses can demand it. The doctors need to demand it, because the doctors aren't able to practice medicine. Their life work is to bring medical science to serve the interests of their patients, and they don't know that they're not getting the right information to do that. And their life work is being undermined. And of course, consumers need to play a major role in getting this straightened out, because the industry creates this illusion that we're going to innovate our way out of this mess, and we're just going to innovate our way deeper into this mess.
So one last question I have is, I feel like a lot of consumers, or it could be employers listening, would say, well, this has got to be the doctor's problem. The doctors have associations. They should be demanding this. They should be fighting for this. Why aren't the doctors doing anything?
Yeah. So the doctors' associations are taking money from the drug industry. The nonprofits that inform the doctors, the American Diabetes Association, the American Heart Association, they're taking money from industry. The National Committee for Quality Assurance that sets the standards for quality for outpatient medical care, they're taking money from industry. And the access to the real information and unbiased analysis is just blocked in virtually every direction that you look. And it makes perfect sense, because the pharmaceutical companies and the device companies, their job is to maximize the profits that they return to their investors. And that's their obligation. The executives who run those companies have an obligation to do that. And without guardrails, it's like playing the Super Bowl without officials. It's going to be mayhem. And what we've got is the most powerful interests have taken over the definition of what legitimate medical knowledge is. And the docs don't even understand that peer review is not based on transparency.
A lot to take in. It makes
And
it makes no, it
yeah,
makes me quite it makes me realize you got to just be active and stay healthy, because in the future, all these medications for all these ailments that I'll probably have when I get older, you know, I can't necessarily trust them. And I just need to it's going to be difficult to know what drug. I just had a family member who just went on a drug that's, in clinical trial, that's supposed to be this potential, the only game changer, that could solve that specific medical issue, but then you question, like, you don't even know if that's the case because of how the pharma companies are manipulating this data.
that's correct. And to leave on an optimistic note, 80% of our health has to do with how we live our lives. And for some folks who are socioeconomically less fortunate, it's very hard and impossible to live a healthy lifestyle. For people who are employed, they're going to have many more options about how to pursue that healthy lifestyle. So 80% of our health is how we live our lives. And no more than 20% of it is the medical care we get. That said, medical care is very important. I've benefited greatly from medical care. I think we all have, and our family members have. But 80% of our health is how we live our lives. And let's not be mesmerized or distracted by the glitter of innovation.
I think it has to, it really makes us look deep as to what is innovation, and to kind of watch it carefully. So I really appreciate you joining us and kind of sharing this inside intelligence, because it's very difficult to get this information in the industry. And then, just like you said, how the pharma companies are, big supporters financially of the medical associations. They're also some of the biggest supporters of a lot of employer coalitions and other associations. So they're making sure that their fingers are in the pockets of anyone who could have any influence over this.
Well, let me just say that to the extent that the pharmaceutical companies are philanthropically contributing to employer associations to help them figure out how to provide better value-based care, I doubt the employer associations are coming out ahead on that deal.
I'm sure they are not, because I think the one thing we could we realize is they're very good at marketing. And for anyone who's listening or watching this, one show I recommend you watch on Hulu is Dope Sick. It was just a really great show with Michael Keaton, and it kind of showed the brilliant marketing and what goes into pushing drugs out there, and also having a better understanding of what the FDA's role is or isn't in these medications. And it's really, Dr. Abramson, I think, is, probably the top national leader. But, that show brings home, if you're a visual learner, everything he's sharing, and then helps open your mind to, I need to look at this totally differently. And if you've seen it, I think you'll have a good laugh, after watching this. So thank you so much for joining us, Dr. Abramson.
It's been my pleasure. Thank you for the opportunity.